Hello, everybody. How you doing?
Hello, good and you?
Getting a swamp cooler installed, and so they disconnected my Wi-Fi 2 minutes before my class was supposed to start. So I'm using my phone as a Wi-Fi hotspot for my computer. How about that? That's one of the reasons why I'm late. I'm actually using my phone as a hotspot. Okay, folks, I know we're running a little bit short, but we have several chapters to cover today. We have chapter 20, part B and C, and chapter 18, and we have review for the exam. Plus, we have anybody who wants to go over exams from last week. So we have a lot to do. I'm going to go ahead and get started, and I'll be adding people as they arrive. Okay, so here we go. We're going to go with 20B. Okay. Okay, we got people coming in right now. Wait just another moment or two, and then we'll get started. Okay, so today we're talking about blood flow and the control of blood pressure. So here we go. All right, blood vessels in the cardiovascular system. Arteries are always blood moving away from the heart. Remember, I got to go quickly. So if you haven't filled in your notes, then you need to do it afterwards, or you're supposed to do it before, but I'll be going through this very quickly, so you won't have time to fill it in as we go. Okay, they are strong and elastic. That allows distension. That means stretching. Large arteries assist in the pumping of blood, primarily through elastic recoil. I'll be talking about that later. They conduct blood to the capillaries through the arterioles. They are thicker than veins, but do not have valves because the pressure is higher as well as the velocity. The walls are thicker, but the lumen, which is the center, is smaller. And we'll be talking about the significance of why there's a large lumen in veins here in a bit. Capillaries are the only place where anything biologically enters or exits the blood, and that's where gases, nutrients, and wastes are exchanged. Veins then return blood to the heart. For most veins, it's deoxygenated blood. If it's pulmonary veins, it would be from the lungs, and it will be oxygenated. They do contain valves that prevent backflow of the blood, primarily against gravity. The only exception would be veins anywhere above the heart, that'd be head and shoulders. So because blood is under lower pressure, coming from your feet and hips and chest, the valves are necessary to prevent backflow and to keep the blood moving up towards the heart. Okay, what are the walls of arteries? The inside is called the endothelium. It's smooth to prevent rubbing of the red blood cells against damage of the red cells by a rough inner surface. It can help regulate blood pressure and regulate growth and diffusion of minerals in materials in and out of vessels. Elastic tissues are also found in arteries. This is the rubber band sort of material there. What happens is during ventricular systole, which is the beat, they stretch out as blood pushes in. They stretch out and then they snap back with force. By the way, if you do hear any weird noises, it's because there's people in my attic putting in a swamp cooler as we speak. All right, what this does is it evens the flow of blood as the heart beats. So as you guys know, there's a ventricular systole and then diastole. Now, normally during diastole, there wouldn't be any blood flow, but because of the elastic recoil of the large elastic arteries, it does push blood between ventricular systoles, evening the flow. Even though there's a little bit of a surge in the arteries, by the time it gets to the capillaries, it's a fairly smooth flow of blood. There's many layers of smooth muscles. These allow vasodilation and vasoconstriction. Vasodilation would be if the circular smooth muscles relax. Vasoconstriction would be if they contract. Fibrous tissue. You also find this fibrous tissue that maintains the integrity of the vessel. That would be very similar to those fibers that you find in the wall of a tire that prevent blowouts. It prevents overstretching of the vessels. Okay, moving on. Now, looking quickly at these, you can see a comparison. This figure is not in your text, but you can see a comparison between arteries having thicker walls, veins having the larger lumen, and also notice what the different compositions are. So in arteries and veins, you find a pretty good amount of smooth muscle. Then when you get to arterioles, capillaries, and venules, much less because the pressure is going to be much lower. But you do find more stuff here in the vein because these also have to protect against physical damage in the skin. Okay, this is a figure directly from your text. It shows you the different layers. Notice that there's more smooth muscle in the artery and other materials that you would not find in the veins. But even though this isn't showing the whole thing, the lumen or center of the vein is going to be larger. Okay, so this shows you elastic arteries versus muscular arteries and arterioles. Notice how much thinner they are. This has it magnified, but the elastic artery is going to be the thickest, muscular artery next most thickest, and the arteriole is going to be relatively thin. And it's also showing you different types of capillaries. Continuous, meaning very small gaps, fenestrated, meaning small holes, and then sinusoid, meaning large intercellular gaps, primarily so white blood cells can move through. Okay, here's veins showing you the different things. Notice that there's much less muscle tissue than you would find in a large artery. And they're also showing valves here, the valves to prevent backflow. And then the venule is going to be very similar to an arteriole, but on the opposite side. Okay, talking about metarterioles, they can cause blood to bypass capillary beds in atriovenous bypasses. And that's what this figure from your book is showing. So when these precapillary sphincters are closed, the blood moves through the metarteriole, shunting blood from the arterial side to the venule side. When these precapillary sphincters open, the capillary bed perfuses with blood, and you would blush or get plenty of blood going through that small capillary bed. So what these metarterioles do is they allow large cells like white blood cells to bypass the bed unless they are needed in that capillary bed. The sphincters regulate blood flow into and through the capillary bed, as you can see from the figure. They're responsible for local redness, such as blushing, and thermoregulation. So for example, if it was in your skin and you were hot, these precapillary sphincters would open, perfusing the skin with blood, dumping heat to the environment. And if you're cold, they would close, making you more pale and reducing blood flow through the skin. Okay, notice that what's happening here, this is showing you a vein in your leg, and this shows you during relaxation, and then there's blood in here. Now, when you contract this muscle, in this case, it's the gastrocnemius, which is your calf, it squeezes the blood. Now, you would expect blood to go both directions, up and down, but because the valve is here, it pushes blood upwards. So walking actually helps pump blood from the lower extremities back up to your heart. So veins and venules have thinner walls. There's a larger diameter, and this is what is called the venous reservoir. Now, what is the venous reservoir? Well, you have a whole bunch of extra blood in case of emergency. So for example, you can give a pint or two of blood and not have a serious problem with your blood pressure. Now, why is that the case? Well, when you give up a pint or two of blood or lose a pint or two during a injury, what happens is blood that is being stored on the venous side in the large lumens or large empty spaces in there move over to the arterial side. And how do they do that? The smooth muscle cells in those constrict, reducing their cross-sectional volume, and that functionally pushes the blood over to the arterial side so you can maintain systemic blood pressure and maintain flow to important structures such as the brain, the lungs, and the heart. Okay, you're going to find these closer to the skin. They help with temperature regulation. As I mentioned, if you move blood closer to the skin, you're going to dump heat. If you move it closer to the center of the body, you're going to retain heat. So you find less muscle in these vessels. They do not actively push the blood. The blood is either pushed by muscles around it or by blood pushing up from below. They're less elastic. There's going to be less rebound effect. And that's not a problem because the surge, ventricular systolic surge that you would find on the arterial side is missing. On the venous side, I'll show you a figure coming up that illustrates that. It possesses valves that maintain one-way flow against gravity. And this is exactly what we're seeing in the vessels of the leg, helping to push the blood upward. So walking actually really does help circulation. Okay, angiogenesis. Now, angiogenesis means growing new blood vessels. Now, during body maturity and growth, you do need new blood vessels. For example, when you're going from a small child to an adult, you need more and larger blood vessels. You're also going to get more vessels, especially capillaries, during endurance training. So when you're hypoxic, meaning you have very less oxygen in your blood, what that does is it stimulates your body to produce more capillaries to allow more oxygen to your tissues. And so you would get more blood vessels there. Now, the only place you don't want new blood vessels going is into a tumor. So if there's abnormal growth, it can feed cancerous tissue. Part of what new cancer treatment is trying to stop those blood vessels from going. So angiostatin and endostatin can inhibit angiogenesis. And the reason why that's not a problem is because as adults, we don't need new blood vessels unless we are training, endurance training. So if you can cut off all the new blood vessels in the body, then that prevents the tumor from getting larger. And so these chemicals, medicines can be used by doctors to starve the cancer cells to death by reducing angiogenesis. Another strategy is to train white blood cells to attack tumors. We'll be talking about more of that in the upcoming chapter. So in wound repair and consequences, if they don't regrow in heart tissue after a heart attack, it can be a problem. And if they don't regrow in a brain after a stroke, it can also be a problem, both of which would lead to problems with healing the tissues that would be damaged during a heart attack or a stroke. Okay, pulse pressure is generated by ventricular contraction. So pulsatal pressure is the surges in pressure that you find in the arteries after ventricular systole. And this is assuming ventricular systole, so write that in if you don't know it. Elastic rebound evens and maintains the pressure. I'll show you some figures that illustrate that. So for example, when this is a highly stylized ventricle and large elastic arteries. So when the ventricle contracts, it pushes blood into the elastic arteries. This pushes outward. This is cartoonized or exaggerated to show you the blood moving from the ventricle into the arteries. Now, when that happens, you've stored a lot of energy in the elastic fibers of the artery, and that can be used, that force can be used to push blood down the line during ventricular systole so that the blood doesn't stop. So you can see this is happening, and then this is what is happening during ventricular diastole, relaxation. The valve is a semilunar valve, and then you see the elastic fibers pushing inward and then continuing to push the blood down the line. I don't believe these figures will be on the test. They are there to help illustrate the point. Okay, blood pressure. It's expressed as systolic over diastolic. The average is around 120/80. I think that ideal is slightly lower than that now, maybe 110/70. But for many, many years, this was considered normal and ideal, 120/80. So you measure it in the radial artery of the arm. You guys have all used a blood pressure cuff, or sphygmomanometer is what it's called. And what it does is it estimates pressure. Now, what do we mean by an estimated pressure? Well, the pressure changes from the aorta all the way down to the capillary. So when you measure it at the radial artery, you're getting an estimate of overall pressure, and that's the number that is used to calculate blood pressure. We're going to be talking about what Korotkov sounds are, and this is what you would be doing if you take blood pressure with a sphygmomanometer and a stethoscope. Okay, so what are the steps? I may be asking you about this figure. It is in your notes, so please take notes and make sure that you know what is happening at each of these stages in this figure. Okay, here, when you guys first get the blood pressure cuff inflated, it's way higher than the healthcare professional believes would be your highest systolic pressure, usually up to 180 or 200 millimeters of mercury, very uncomfortable. So what that does is it completely cuts off the blood through the radial artery and into your entire arm, and you don't hear any sounds, and there's no blood flow. Now, as they start to relieve the pressure on the bulb, and that releases the pressure on the cuff, what happens is, as soon as the pressure in the artery just barely exceeds the pressure in the cuff, what's going to happen is little squirts of blood are going to shoot past the cuff, making sounds. That is turbulence. The turbulence makes a noise, and you can hear that through the stethoscope. So that's the beginning of systolic pressure. Then as you continue to release pressure, what happens is, as soon as that whooshing sound stops, you know that the pressure of the cuff is equal to diastolic pressure, and then that would be recorded as diastolic pressure, or the bottom number. So I may be asking you what is happening to A, B, and C, be able to answer those. Okay, mean arterial pressures. What is pulse pressure? Well, it's systolic pressure minus diastolic pressure. So the difference between diastolic and systolic. For most people, that would be about 40. Pulse pressure would be 40 when you subtract 120 from 80, or 80 from 120 then. What is mean arterial pressure? I will be asking you to be able to calculate this. So it's diastolic plus 1/3 of pulse pressure. So for example, if pulse pressure was 40, you took 1/3, that would be about 13 plus diastolic, which is 80. So mean arterial pressure for most people would be right around 93. And this is a figure showing this. This is likely to be a figure on your upcoming exam this week or next week. I can't remember if this chapter is on this week's test, but if it is, this is going to be a figure that I'm going to be asking you about. Now, at the end of the lecture today, make sure to remind me to show you the actual essays. And by the way, one person did this, but I got to tell everybody, do not submit attachments for your essays on exams. You have to copy out of the word processing document and paste it into the test. I will not be accepting that anymore. I don't like attachments in tests. It's just doesn't work well. So please make sure to copy and paste into there. Please make sure also don't copy off the internet. Some people are losing points because they're finding stuff out on the internet, and I check it, and you're going to be getting a 0 for this. So please don't do it. All right, let's go through this. Now, what we're doing here is I don't remember. I think I've already introduced this figure in a previous chapter, but this is the chapter I think I'll be asking you about it as an essay. So what's happening here is if we were in the ventricles, you would see the diastolic pressure, instead of going down to somewhere around 80, it would go down to 0. But now we're in the aorta. It does not go down to 0 because the pressure is still pushing outward even during ventricular diastole, relaxation. And as you move further along, what's happening is the mean arterial pressure and pulse pressure are also decreasing. So there's a slight increase in pulse pressure here in the elastic arteries and a decrease as you move forward. In addition, the overall mean arterial pressure, or MAP, is dropping off. Notice that the biggest drop off is in the arterioles because there's a huge amount of bifurcation, that means splitting, as well as a much greater cross-sectional area. Now notice by the time you get to the capillaries, the surging has completely stopped. It's a nice flow. It's shown purple. This is where gas exchange is happening. Still between the beginning and end, a drop in pressure. We're going to be talking about how does that generate lymphatic fluid, what's happening right in this purple thing when we get to lymphatic system. And then you can see it continues to drop off, but very slowly. And then right at the vena cava, it drops off basically to 0 as it re-enters the right-left atria. So if it's on there, be sure to tell me what is happening here. You want to check your book. This is in your book. When I say check your book, that does not mean copy out of the book. It means read it and put it in your own words. Okay, so since I have talked about it a little bit before, I'm not going to give as much detail there, but make sure on your essays to give us plenty of detail as you can, including examples and analogies where appropriate. Moving on. Okay, what drives blood pressure? Well, primarily it's blood volume. It's a balance between fluid intake, what you swallow and drink, and loss through the kidneys and or evaporation. Now, if you wonder, where's my face? I've been having issues with unstable internet connection, and I was hoping that by not adding my face video, the video from me, it would stabilize my internet connection. Okay, so you drink some, which increases your blood volume, and then you lose some through sweating, evaporation through the respiratory tract, or through generation of urine. Cardiac output, what is that? That's how much blood is leaving the heart. Stroke volume, how much it goes in a single ventricular systole times the heart rate. So if stroke volume increases and heart rate increases, which is usually the case during exercise, your cardiac output, or total flow of blood leaving the heart, rises. Resistance, what slows blood moving through the blood vessels? It's primarily the diameter of the arterioles. I think I mentioned before, it can also be viscosity, which is the thickness of the blood, as well as the length of the tubes, or length of the blood vessels. Distribution of blood. If you want blood to move into a particular part of the body, you increase the diameter of the vessels. That will cause more blood to flow. And if you want to restrict blood through a body part, you vasoconstrict, reducing the cross-sectional area. That increases resistance and decreases flow. Okay, what is shock? It's a generalized severe circulatory failure. So when someone is surprised, they're not really in shock. Shock is a medical term, which means that unless something is happening, if something is going to happen to, oh, Matthew says, haven't had any freezing. Well, I think it's because, Matthew, I'm using my phone as a Wi-Fi hotspot. I can't do that all the time because they only give me a certain amount of data, but I didn't know if my internet was going to come back on, so I went ahead and hopped on my hotspot, which is ironically much faster than my home internet. And that's why I need one of those Wi-Fi hotspots. They're called jetpacks. And I'm trying to get one. I hopefully can get one soon. All right, so this is a medical problem, which means that the circulatory system is not delivering adequate blood to the tissues, most importantly, not adequate oxygen. So what can cause it? One of the primary ones is a reduction in cardiac output. And this is called cardiogenic shock if your heart is not pumping well. And this can be due to a cardiac event, heart attack, anything like that. For whatever reason, your heart is not pushing the blood out as much as it should. Another cause could be increased blood volume, which would be hypovolemic shock. You have lost blood due to an injury or some other thing during a surgery, let's say. Septic shock or toxemia can cause shock. That is, toxins in the blood can cause problems with circulation. You can have a severe immune reaction. Anaphylactic shock, you guys have heard about this. This often happens when people get stung by bees or they eat the wrong food. Now, what is the reason why you get anaphylactic shock? Well, what happens is one of the responses of the body during anaphylaxis is massive vasodilation, which you might think is good, but if everything opens up, that causes the blood pressure to drop. When blood pressure drops, flow drops as well. And you can die from that because your blood pressure just drops and drops because all the blood vessels are opening up. So how would you diagnose this? Very low, diagnose this. It would be low blood pressures, pale and cool skin, because you're not getting enough perfusion through the skin to warm it, make it pink, and lack of responsiveness. There can also be confusion in the patients. Now, this is what is called a positive feedback because a lack of circulation can cause problems with the heart. The heart is a muscle that needs to be fed, and oh, come on. And so if you're not giving the heart enough oxygen, then it will pump blood worse, more poorly, excuse me, and it will, the whole problem will become worse, and you can die from it. What is the treatment? Oxygen, fluids. By the way, what do you guys think? Do you think that giving somebody something to drink when they're in shock would be a good idea? And why?
Probably not.
I would
because
say
they mentioned-
no.
Well, wouldn't giving them something to drink increase their blood volume and then increase their blood pressure?
I would be worried about their body not functioning properly and choking on fluids.
Yes. Yeah, you don't give somebody in shock something to drink. You give them IV fluids because if they vomit and aspirate, they can die. So yes, do not give somebody in shock something to drink. That's what you would do later on if they don't have a high chance. Nausea is one of the also the symptoms or something that comes from shock. And norepinephrine, by the way, do you think it's the correct way to administer norepinephrine by taking a large needle and slamming it into the patient's chest as hard as you can from
No.
way up above? So why do they do that in movies?
Because
Why
it
do they
looks
say
cool
someone-
and scary.
Yeah, it's cool and scary, but what happens if you hit the breastbone, the sternum, or one of the
You-
ribs?
You probably break the needle and just have an even bigger problem.
Yeah, or what if you hit the lung? Yeah, they
Yeah.
wouldn't do that. Medical people wouldn't do that, but you see it in movies all the time, and I always roll my eyes and start going, ah, because they know that most Americans don't know medicine or anatomy or physiology. So anyway, I thought you guys might find that interesting. This is a figure showing you kind of how mean arterial pressure is generated through variable resistance in the arterioles and cardiac output, kind of like a machine. This figure is not going to be on the test, but it's kind of an interesting figure overall. All right, blood pressure. Blood pressure control involves both the cardiovascular system and the renal system. So cardiovascular is going to be instant, renal is going to be more long-term. So how does blood blood pressure work? Well, blood volume is going to be determined both by fluid intake and fluid loss, which could be passive, that is sweating or basically sweating or evaporation, or regulation at the kidneys. You can also get blood pressure determined by heart rate and stroke volume. So if those decrease, your blood pressure decreases. The blood pressure could also be the diameter of the arterioles. Remember I said when the arterioles open up, blood pressure drops, and when they narrow, blood pressure rises. And the diameter of the veins can also affect it. So all of these factors work together to give you your overall mean arterial blood pressure. Okay, well, that is it for chapter 20B. Now we're going to jump directly to 20C. Does anybody have any, let me see, where are we? Here we go. Does anybody have any questions about what we just went over before we go to the next chapter, 20C? Okay, we'll do questions at the end. Okay, a little bit more about blood flow and blood pressure. Off we go. Where does blood go in the body? Well, it responds to metabolic need. Areas with the most need receive the most blood. So that would be where vasodilation would occur. Vasoconstriction would mean you'd need it less. So you guys have heard the old story, don't go swimming after you eat. Why is that the case? Or don't run after you eat? Because the body is trying to move blood to the GI tract rather than the muscles. And if you try to move blood away from the GI tract after eating, theoretically, you could get inadequate perfusion to the muscles and you could get a cramp. Now that is more of a cliche than reality, but if you do find yourself in a non-relaxed state after eating, you can have indigestion because lack of blood flow to the GI tract can cause problems with digestion. So it's best to eat and then relax for half an hour or so. But being active people, we often can't do that. So
I have a question.
Sure.
How come they suggest to go on walks after eating?
You know, I've often done that. I think what happens is it helps move blood through your body, but I would recommend a very mild walk, a slow walk. Because if you're doing a power walk, you're going to be moving too much blood away from the GI tract to the muscles. So I think perhaps, you know, I don't know. I mean, theoretically, physiologically, the best thing would be to just relax, sit and be calm afterwards. But I don't know exactly. You certainly wouldn't want to do anything more than a very.
I mean, is this contingent upon the amount of food you eat? Because I know like when we would run marathons, we would be eating while running.
Okay, all right. So that's
you
a
need it
completely
to,
different thing.
You know?
So the idea is if you're an athlete and you want a carb load, yes, you would eat right before, but it would be a relatively small meal and you'd want to give it plenty of time, especially you'd want it to be fairly simple carbohydrates so they could be moved into the blood quickly and then eventually into the muscle tissue. But if you're eating a regular meal and you're not an athlete, if it was a very large meal and then you started exercising anything more than mildly, you could have an issue. But yeah, theoretically, eating while you're exercising could be beneficial, but for most people, it's not necessary. I hope that helps.
Yeah, thanks.
You're welcome. I like your questions. All right. So precapillary sphincters, as we mentioned in the previous chapter, regulate distribution into and through organs because the organs are full of capillary beds. And if you open those vessels, then the blood will move through the capillary beds of the organs. There can be huge variations in flow. For example, skeletal muscle can be anywhere from 20 to 85% of total blood flow. 20% would be when you're resting, sleeping, and 85% would be when you're in intense anaerobic exercise. So as you can see from this figure, which is not from your book, you can see at rest, notice this is at rest. The largest amount is going to be to, where do we have? Liver and digestive tract, 27%, right? Kidneys, 20%. Skeletal muscle, still 20%, but this is going to go way up. So you're going to see skeletal muscle go up, skin go way up. Why would you expect to increase in blood flow to skin during exercise, folks?
So you can sweat?
Yes. So you can dump heat to the outside. So that's going to go up. Liver and digestive tract is going to go down. What do you think to the heart? How much would it go up or down during exercise?
That would go up.
Would go up. right? And then believe it or not, even to the brain, it goes up because the brain is more alert when you're exercising than when you're resting. So some kind of interesting, this is not going to be on the test, but it does show you that changes occur in blood flow to different parts of the body, whether you're at rest or in exercise. Okay, blood flow. Blood flow through 4 identical vessels is equal. Total flow into the vessels equals total flow out. These are some tongue twisters. So 4 in, 1 each out gives you a total of 4 out. It makes sense. Whatever's coming in has to be exiting. Now, if you decrease 1 and you want to maintain the flow in, the other ones have to open, increasing their flow so that you still have a total flow of 4 liters per minute. So if one of them narrows, so not that significant, but it is a thing. Okay, so this shows you the figure that I showed you before, the precapillary sphincters, the through fair channel and meta-arterial, pretty much the same as what I showed you before. This is when the precapillary sphincters are closed, showing you blood flowing through the meta-arterial. Okay, these are figures directly from your book, and I may be putting these on your test, so you need to know what's going on with them. So in this case, we're looking at cross-sectional area versus blood flow. Do they seem related at all? Is there any relationship between the cross-sectional area and the velocity?
It almost looks as it's inversely related.
Right. They're inversely related. So what happens is, as the cross-sectional area increases, the velocity is going to decrease. Now the question is, do you want the blood to slow down at the capillaries? Yes or no, and why? Why would you or would you not want blood to slow down in the capillaries?
You'd want it to slow down because they're quite a bit smaller, which would mean that they would need less pressure.
True, but why would you want the blood to slow down in the capillaries? Is there a benefit to having the blood moving slowly?
Because the gas exchanges and nutrient exchanges
thank
need to
you.
take time.
Thank you. That is it. One of the things that we didn't talk about in Fick's law was time, right? If you want to increase diffusion, you want to give yourself more time. The way the body does that is by slowing the blood down in the capillaries. That gives more time for gas exchange, nutrient and waste exchange. And it does that anatomically by increasing the total cross-sectional area, by increasing the total number of arterioles, as mentioned, and the total number of capillaries. And by doing so, it slows everything down. Notice that the velocity picks up on the far side, moving the blood back to the heart, and the total cross-sectional area drops down again as you leave the capillaries. So these two are directly related to each other. And who said it? Was it Catherine or Erica?
I did.
Erica, good job.
Oh,
All right, where's the question? Where's the lowest pressure in the cardiovascular system? Is it shown here? Is either one of these showing pressure?
No.
No. From a previous figure, you know that the lowest pressure is in the end of the superior and inferior vena cava, right? So you're going to find a lowest pressure in the vessels the veins right before the heart. What this means is that blood slows down in the capillaries. As you see here, the lowest velocity is at the capillaries. This is beneficial, as mentioned, because it gives more time for nutrient, gas, and waste exchange. Hydrostatic pressure drops, see notes from last time. So drop in blood pressure and drop in hydrostatic pressure are related, but that does not have to do with these two figures here. Okay, capillary exchange. Now, this is something that isn't explained very well in your text, but I picked it up off a previous text. So pay attention. I may be asking you questions about colloidal osmotic pressure in the capillaries. All right, we're going to be talking about a thing called bulk flow. Now, when we did talk about Fick's law, we talked about diffusion, right? But if you want to cheat and you don't want to have to do diffusion through a blood vessel and then through the extracellular fluid and then through the membrane of the cell, what the body does is it leaks part of the fluid out of the capillary, putting it right up against the cell, reducing D. So what's happening here is some of the liquid is leaking out of the capillaries on the arterial side, coming up right up against and contact with the cells that need it, and then being drawn back in somewhat on the venous side. How does this work? I will tell you, but what it does is it reduces D in Fick's law increasing diffusion, and it's just a way to cheat the system, which your body does. Okay, this is due to hydrostatic or osmotic pressure gradients. So hydrostatic would be blood pressure. Now, if you remember the figure from previous chapter, blood pressure is higher on the arterial side of the capillary than it is on the venous side. So it drops, pressure drops from arterial side of the capillary to venous side. And what that does is it means there's going to be higher pressure coming in than leaving. So what we're seeing is if fluid is going into the capillaries, it's called absorption. So for example, in the capillaries of your GI tract, your stomach somewhat, your small intestines especially, you're going to be drawing in more fluid than you're losing. That's called absorption. If it's going out of the capillaries, it's called filtration. Now note, filtration has nothing directly to do with cleaning the blood. Now, when we talk about filtering things, we think about something being cleaned, but really what a filter does is not cleaning anything. And the best example I can give you is, what does a coffee filter do? Does it clean your coffee? You guys have all used a coffee filter before, I assume.
No, it stops you from getting coffee
Nope.
grounds in your cup.
Right. That's literally what filters do, you guys. They separate the chunks from the liquid. So a coffee filter keeps the grounds out of your coffee. And so in the kidneys, what we're going to see is you're separating the cellular elements, the cellular fragments and cells from the plasma, and that's filtration. So filtration just means separating liquid from solid. So a new definition for you. Okay, now the proteins always stay in the capillary because they're very large. In most of these capillaries, the holes in the capillaries are too small for the proteins to leave, which means that once fluid has left, the remaining fluid is slightly saltier due to the presence of the proteins, and some of the fluid is now gone, so it's slightly saltier. But water, oxygen, and glucose move out of the blood into the tissues of the body, so they actually leak. You guys have seen a soaker hose before, right? The stuff that kind of oozes water in a garden. So that's kind of how it works. The body oozes fluid out of the capillary into the extracellular space. Gas exchange occurs, and then some of it goes right back in. How does it go back in? Because of the increased saltiness of the blood due to the presence of the proteins that never left. I'll show you. So CO2 and nitrogenous wastes move into the blood. That means you're picking them up to take them away. And so these are the things being picked up by the venous side of the capillary. And this up here is what is being dropped off. And this, by the way, this is at most body tissues. The reverse would be true either in the kidneys or the lungs, depending on what's being removed from the body. So here's the key to the whole thing. Bulk flow is always out on the arterial side and in on the venous side. How does this work? I got to show you the picture. Okay, this figure is not in your text, and it looks confusing and very mathematical, but it's not. So just go with me on this. Now notice that what is happening here in the blue line is blood pressure. And notice it's going from fairly high on the arterial or red side to fairly low on the venous side as a slightly pretty much gradual drop off. Now notice on the arterial side, it's higher than the colloidal osmotic pressure. That is the ability of the blood to pull fluids back due to osmosis. So because the blood pressure is higher than the saltiness of the blood, you're going to see outflow. So the fluid missing the large plasma proteins is going to leak out, go right up against the cells. Now, when we get to the venous side, look at the opposite is the case, because the colloidal osmotic pressure remains the same, but the overall blood pressure is dropping off. So on this side, you notice that the saltiness of the blood exceeds the pressure. So you're going to get absorption back. So it leaks out here, does this exchange, and leaks back in, or is drawn back in. But what do you notice? You notice the total size of these arrows is less than the total size of these arrows. What does that mean? It means that you're going to have more loss of fluid than reabsorption at the regular body capillaries. And 2 liters a day is about what is lost. The key to this is this 2 liters has to be moved back into the blood eventually, or your body will swell up. And that's what happens with edema to a slight extent and with elephantiasis to a great extent. And I'll be talking about elephantiasis a little bit later, I think. So this is only to show you that there's outflow on the arterial side and absorption on the venous side because drop off in pressure.
Is this the
Okay,
same
so
thing
this-
that happens during venous stasis as well?
I'm not sure. Can you define venous stasis?
Venous stasis has to do with when lymph leaks out of the blood vessels, causing edema as well. But
Yeah.
typically you'll see discoloration in the skin because your body responds to the lymph leaking outside of the blood vessels.
Yeah, and that would be a pathology. But what I know that you guys are going to be focusing, a lot of you are going to be focusing on pathological issues. What I tend to focus on this class mostly is normal body physiology. So I may not have as much to say about various pathologies because the pathological side of physiology isn't my specialty, unfortunately. I'm really a biology teacher who's doing physiology. So I hope that's not too distressing to you. But I believe that you will be getting a pathology course as part of your nursing degree or whatever healthcare degree you're going for. Sorry, I couldn't give you a better answer than that. Okay, let's get back to this. So as I was telling you, net loss on the arterial side, net absorption here, and then what's left over has to go into the lymphatic vessels. Now, the lymphatic vessels have to do with immunity, but one of their big jobs is taking the fluid, the excess fluid that's leaked out that cannot be drawn back and getting it back to your heart. So what happens is it enters here. And what's interesting about the lymphatic vessels, it's different from arteries and veins, et cetera, is that they do have a beginning spot. And you see they begin right here. So one of the questions says, what is the difference between lymphatic fluid and extracellular fluid? And the answer is nothing other than location. So if there's fluid in here and it doesn't get drawn back into the venous side of the capillary, it ends up in the lymphatic vessels, given you don't have edema or elephantiasis. What is elephantiasis? I'll go ahead and explain it here. If you get a filarial worm in a third world country, especially Africa, what happens is these nematode worms burrow into your body and take up residence in these lymphatic vessels because lymphatic fluid has plenty of oxygen and nutrients, etc. There's also not going to be a lot of white blood cells in there. And if you get enough of these worms blocking the lymphatic vessel, what happens is this fluid can't get back to the heart and it accumulates. And so elephantiasis was named that because people who have it, their feet look kind of like elephant feet. And it's due to the fact that it cannot get back because worms are blocking it. Doesn't happen much in the United States because we have advanced medicine. Happens more in third world countries. Okay, so net filtration is equal to the net absorption, net filtration minus net absorption is equal to the net outflow. As we saw in a previous slide, that's about 2 liters per day for most people. 2 liters per day is collected by lymphatic vessels. Oh, by the way, in what way is a pregnant woman similar to someone with elephantiasis? Anybody want to take a shot at that?
Does that have to do with increased blood flow?
No. Remember what I said, elephantiasis is due to a blockage of these vessels preventing the lymphatic fluid from returning to the heart or the vessels just above the heart. What is happening to a pregnant woman, you think, that can block the
baby?
The baby is pressing against the large vessels against the posterior body wall and preventing the fluid from getting up. That's why some pregnant women, especially in the last trimester, tend to get edema because the baby's weight is pressing against those lymphatic vessels. Now, lymphatic vessels are very much like veins in that they have low blood pressure and valves. And so if there's pressure being put against those vessels, it's going to prevent or reduce the flow of lymph back to the heart, and you can get edema. So there you go. So where do the lymphatic ducts return liquids to the CV system? Well, you got to think, where's the lowest pressure? Now, earlier in this lecture, where did I say the lowest blood pressure in this cardiovascular system is? You guys remember, where's the lowest pressure?
The vena cava.
Capillaries.
Right, the vena cava.
Oh.
So if you want to return a very low pressure fluid to the blood, you don't want to do it into a high pressure area because it will go into the lymph rather than going into the blood. So by having it go into the superior vena cava or nearby, the blood pressure is so low that it actually draws through the Venturi effect, which I don't have time to explain, you can look it up. It actually sucks that lymphatic fluid into the blood, returning it and mixing it with venous blood. And that's how you get this lymphatic fluid and this tissue loss, fluid tissue loss back to the blood. All right, what are some of the lymphatic structures? Well, you have lymphatic capillaries, which have a similar name, but remember, they have a beginning and an end rather than being a circuit like your normal blood vessels. They're very thin-walled with gaps. What are the gaps for? To allow the fluid to leak into them. What are the functions of the lymphatic valves? What are the functions of the valves and veins? Is to prevent backflow of the fluid due to low pressure within the system. So by maintaining the fluid always moving back towards the heart or the vessels above the heart, it keeps the lymphatic fluid always moving back. Now, question, how could exercise help reduce swelling? Think about it.
Increase movement of the blood.
Right. Well, it's increased
And
movement
then
and you squeeze the muscles, right? You squeeze the muscles. Not only does that push venous blood forward, it also pushes that lymphatic stuff forward. So if you do have a slight amount of edema, walking can help push that fluid upwards by not only generating more pressure, back pressure from the entire system, but mostly when you squeeze on any of the larger vessels, you're going to push the lymphatic fluid upwards. That's going to reduce pressure in the feet and legs and therefore reduce swelling. So my daughter's mom would walk a lot when she would get edema because what the contracting the muscles in the legs would reduce edema due to that very function. Okay, so as I said earlier, lymphatic fluid is just interstitial fluid found inside a lymphatic vessel. So I asked the difference. The only difference between them is their location. Interstitial fluid is the fluid found between the blood vessels and the cells, and lymphatic fluid is just that same fluid now within those vessels. Lymph nodes and organs. Now we're going to be talking a lot more later on about what lymph nodes do in the immune system, but fundamentally what they do is they filter the lymphatic fluid. And the reason why that's a better fluid to filter is because blood is full of chunks, i.e. red blood cells. So if you want to find a needle in a haystack or a very small protein that could be from a bacterial cell upstream, you would want to filter the lymph. So what happens is these lymph nodes act as filters, and they're picking up, kind of like filter feeders in the ocean, picking up any small substance in the lymph that could potentially indicate that something's not right upstream. And if they do pick up a bacterial protein, an antigen, they can trigger an immune response, which I'm going to be talking about later on in the upcoming chapter. Pumping is due to smooth muscle contractions in larger lymphatic vessels. There is some pumping in the larger vessels, but primarily due to movement of your body and due to those valves. Interestingly, one of the jobs of the lymphatic system is to transport fats. It does so in small bubbles called chylomicrons. I'll talk more about chylomicrons when we get to the digestive system. But the key, the most important thing that the lymphatic system does, besides helping with immunity, is getting extracellular fluid back into the plasma by returning it large vessels above the heart. Now, mentioned before, edema is buildup of lymphatic fluid. I mentioned elephantiasis due to a parasitic worm blocking those lymphatic vessels, preventing the fluid from making it back to the heart. And there's a picture of what it looks like. Does not look very comfy, does it, folks? That's what happens if you get a blocked blood lymphatic vessels. All right, this is a picture directly from your text showing you how the lymphatic system works. It's showing you what is happening in a lymph node. Notice the valves here. Valves coming in and valves exiting. But primarily what happens is these tissue cells are in here and all the white blood cells are gathered around pulling out potential antigens, foreign antigens. Thymus is primarily for developing T cells, thymus-derived cells. This is part of immunity. But pretty much your main thing are the vessels and the nodes in terms of the non-immune side of the lymphatic fluid. So this is a picture from your book. All right. Regulation of blood pressure. There's a cardiac control center in your medulla oblongata, which is the inferior most part of your brain, primarily really just the top of your spinal cord. So you have a thing called a baroreceptor reflex, and it's kind of interesting. Now, if you guys ever noticed, if you have relatively low blood pressure, when you stand up really quickly, you get a little lightheaded. Now, why do you think you get lightheaded when you stand up from a seated or prone position quickly? What do you think causes that? You get a little bit lightheaded or dizzy.
That's generally low blood pressure.
Right. So when you were laying down or sitting, you don't need much blood pressure because you're not fighting gravity and you're not exercising. But when you stand up, what is the main component of blood?
Fluid?
Water,
Water.
right? And if you take an object full of water and stand it up straight, the water's going to want to go down towards the feet, right? And it does. So what happens is, because your blood pressure is low and because your cardiac output is low, the blood wants to drop down. That's kind of a big deal in a movie called Top Gun Maverick. Have you guys seen it? If you haven't seen Top Gun Maverick, you got to go watch it. He's my boy, Tom Cruise. And one of the things in that movie is making sure that you don't pass out due to the blood moving down into your feet. And pilots have a G suit, which is supposed to squeeze on their legs and abdomen, preventing the blood from going down to the feet, maintaining it in their brain so they don't pass out and crash a $10 million plane and kill themselves. So what happens normally if you're not a pilot is when you stand up, you have this baroreceptor reflex, and when the baroreceptor reflex happens in your medulla oblongata, and when it senses the drop in blood pressure there, you increase cardiac output within a couple of heartbeats, and you don't pass out usually. So the carotid and aortic baroreceptors sense pressure due to stretch of the vessels, and blood pressure is adjusted normally within 2 heartbeats of the stimulus. Now, if this doesn't happen, you can pass out if you don't increase your cardiac output when the blood's trying to move down into your feet. Now, long-term, kidneys regulate blood pressure by changing blood volume. They do that by how much fluid is lost due to urine and how much is retained, taken back from the filtrate. We'll be talking about that when we get to renal coming up. The hypothalamus and cortex of the brain, stress or other mental states can increase or decrease blood pressure. I remember reading books when I was back in school that when a lady would get bad news about her husband passing away in war, she would pass out. Why would that be the case? Is because an emotional stress can cause a drop in blood pressure, believe it or not, and you can pass out from that. It doesn't happen as much as it used to. Most people are a little bit tougher than that, but you guys have all heard that thing where the person says, I have some bad news, you might want to sit down. Why do they tell them to sit down? Because it's still a cliche that if you get really bad news, you could potentially pass out due to stress or a decrease in blood flow to your brain. So that's why they want you sitting down. So if you do pass out, you won't fall down. Some little factoids there. Okay, cardiovascular disease. Coronary artery disease accounts for the majority of cardiovascular deaths. Blood vessels of the heart are blocked. The heart does not receive enough blood, which is primarily oxygen and nutrients. What are some risk factors? Smoking can do it. Now, why smoking? Smoking causes vasoconstriction, decreased blood flow, especially places like the heart. Obesity can increase the length of blood vessels in addition to making the heart having to work harder. Diabetes can cause all kinds of problems, and genetic predisposition is something you can't do much about. Although you could find this out by doing 23andMe, and it might make you want to be a little bit more cognizant about your coronary vessel health. All right, so what are some cardiovascular diseases? Hypertension is chronic high blood pressure, and stroke can be a rupture of the cranial artery or a blockage of a cranial artery. Okay, so there we go. That's chapter 20, part C. I know I went through it pretty quickly, but I had some things to say. Last thing we're going to do is chapter 18. Then, well, that is the last lecture. Then we're going to review for the exam, and then we will go over anybody who wants to stick around and go over their exam from this last week can. By the way, for everybody who's listening, please don't ask for an extension because you had a personal emergency. I build in those drop your lowest score for that very reason. I don't give extensions. So if you wait until Saturday or Sunday and then have an emergency, just take it as no harm, no foul. That one drops off your score. But if it happens often, you will notice your grade go down. But please don't ask me for an extension on stuff because you have a whole week to do it. and I need you to get it done by Sunday night. As a matter of fact, Saturday night would be better. All right, enough preaching. Here we go. Chapter 18. Okay, talking about blood. So we were just talking about blood vessels and the blood within. Well, what is blood made out of? Well, the plasma portion is primarily water with ions such as salts, etc., and organic molecules. These are the different organic molecules you could have in there. So these are all the food molecules, and these are wastes. You can have elements and vitamins and gases. Now, the gas that they don't show here that they should is nitrogen. Why do you think that they should have nitrogen as the main gas in your blood? Is it the number one gas in your blood? What do you think? We focus on CO2 and oxygen, but do you know what? Yeah, Matthew, you're right. Nitrogen is the main thing in your blood. So what are you breathing right now? What do we call the stuff that goes into your lungs?
Well, I think most of the air is nitrogen, but even though there's some oxygen in there.
Right. So you jumped ahead there. Yeah, it's what we call air. Most people think of it as oxygen, right? But as you said, nitrogen is the main gas with some small amounts of oxygen and CO2. So the main gas that you're going to find in the blood is nitrogen. This is really significant when we talk about scuba diving. Anybody here scuba dive know that the nitrogen can cause all kinds of problems if you come up too quickly from depth. I'll talk about that a little bit later. All right, talking more about blood plasma. It's the liquid portion of blood, approximately 60%. That number goes up for people who are out of shape and goes down, believe it or not, for people in very good shape. So you would have more red cells than plasma. What's it composed of? As we showed, water, ions, such as salts and sugars, organic molecules, plasma proteins, which are pretty stable. By the way, albumin, the same molecule found in the whites of eggs, is the primary plasma protein. Antibodies, which are also plasma proteins. Urea, which is a waste, and clotting proteins that we'll be talking about later. How does your blood clot? So dissolved gases, mentioned nitrogen, mostly because that's most of what air is. Oxygen, carbon dioxide. Oxygen is what we're taking in. CO2 is what we're getting rid of. What are the cellular elements or formed elements? Erythrocytes is a scientific term for red blood cells. They carry oxygen. When you have more red cells in your blood, it's called increasing hematocrit. And that's one of the things that's checked by a CBC. So when a doctor orders a CBC, hematocrit is one of those things that's checked. Leukocytes are white blood cells. They fight disease by identifying and destroying pathogen. Platelets help in blood clotting. The scientific term is coagulation. I'll be asking you to tell me more about how coagulation works coming up. So this is what the formed elements of blood. So we have red blood cells, which is primarily what's in your blood. Then we have white blood cells made up of these types. Notice that some of them have dots in them and some don't. These are called granular leukocytes. These are called agranular leukocytes because of the grains that show up when stained under a microscope. And the platelets are these tiny formed elements that are full of these clotting proteins that help you clot your blood when injured. All right, white blood cell types. Phagocytes is a type of white blood cell. They engulf and ingest foreign particles such as bacteria and viruses. Lymphocytes, also known as immunocytes, are responsible for immune responses against invaders. So they're responsible for identifying and initiating immune response. What is a differential white cell count, sometimes abbreviated a DIF, D-I-F-F? It estimates the relative numbers of different types of white blood cells. Now, if you notice that a particular type of white blood cells or all the white blood cells are higher than normal, what would you think would be a fairly reasonable diagnosis for a person with high white blood cell count? Anybody want to take a guess? Okay, well, if they're mature white blood cells, you might expect an infection, right? You guys realize white blood cells increase during infection. And if there's large numbers of immature white blood cells, that is leukemia. And we're going to be talking about leukemia a little bit later on. So you would do a diff by doing a smear of blood that has been dyed to show the white blood cells. Normally, you can't see them at all unless you dye it. Certain types of white blood cells will increase in number during certain diseases, as we mentioned. So that's part of what the diff is for. Now, one of the review questions says you and I could do a diff very well right now if we have the right equipment. What does this say? It says requires training. You guys have heard of lab tech before, right? Lab tech. If you guys are going for lab tech, you would be able to do this. But this is what lab techs do. So the question, can you and I do this if we have the right equipment? No, we have to be trained to be able to distinguish the different types. So keep that in mind when you're doing the review questions and the exam. Hematopoiesis, that is making new blood cells. It continues throughout life because we're constantly getting rid of old blood cells and getting new ones. It occurs in the liver and spleen early on and transfers to the bone marrow. Now, why in the liver and the spleen? Because our bones aren't fully formed early on, and we switch to bone marrow, especially the red bone marrow, later in life after birth when our red bone marrow within our long bones and short bones have developed. All right, red bone marrow is actively producing red blood cells, hence the color and name. 75% of marrow cells produce white blood cells, shorter lifespan, more often replaced, about a 6-hour lifespan. Please note, although the average lifespan of a white blood cell is 6 hours, some white blood cells have a much, much longer lifespan than red blood cells. Now, red blood cells have a span of about 120 days, which is 4 months, right? But some white blood cells live a lot longer. So there's a higher variability in the lifespan of white blood cells than red blood cells. Yellow bone marrow contains high numbers of fat cells. Really, that center of your long bones is just for holding fat. This figure shows how different blood cell types are produced. If you're interested, take a look. I do not believe this is going to be an essay, but you can see neutrophils being formed, red blood cells being formed, the loss of the nucleus, and megakaryocytes shedding platelets. We'll look more at that later on. Okay, hormones that control blood cell production. They're called colony stimulating factors, and interleukins regulate the production of white blood cells. The production of white blood cells is called leukopoiesis, which is a more specific version of hematopoiesis, which just means blood. Folks, I'm not jumping into chat as much as I should. Sometimes it doesn't pop up on my screen, so I don't know that you're chatting. If you can get a mic, it would be better. Get my attention better. All right, so if you have too many white blood cells, that's leukemia, and too few is called neutropenia. Now, why is there a problem having too many white blood cells in leukemia? Well, they are immature, they don't do any job of fighting infection, then they crowd out the red cells, thereby reducing your ability to carry oxygen because you have fewer red cells. That's part of the issue. All right, erythropoietin is a hormone produced by the kidneys, believe it or not, and it controls red blood cell synthesis or erythropoiesis. Now, when does this happen? This happens when you go through long periods of time when the body senses that you have inadequate oxygen. So what do people do who want more red cells? They purposely give themselves lower oxygen. And have you guys ever seen those athletes or whatever who wear certain masks that restricts airflow through their lungs? It seems like torture to me. But what that does is it puts you in a state of anoxia, slight anoxia, and it forces your body to produce more red cells. What people will often do is they'll go to Colorado, which is Denver's called Mile High City. And if you go into the mountains above Colorado, the air is much thinner. That causes a reduction in oxygen in your body, and that stimulates your kidneys to produce erythropoietin, which stimulates your red bone marrow to produce more red blood cells. And when you come back to sea level, now you have a whole bunch more red cells. So it's called training at altitude. Thrombopoietin, abbreviated TPO, controls platelet production, which is called thrombopoiesis. Now, this is a scanning electron micrograph of red blood cells showing you the biconcave nature of them. They're the most abundant cell type in the blood, about greater than 90%, depending on the situation of the person. What is their job? Carrying oxygen using the protein with iron called hemoglobin. They live about 4 months. So in the test, you guys aren't going to freak out if I put 120 days, right? You guys realize 120 days and 4 months is the same? Everybody say yes. All right.
Yes, sure.
If you can't do that math, you don't belong in this class. All right. Yes. So yes, 120 days is 4 months. All right. Hematocrit is the ratio of red cells to plasma. Increasing hematocrit increases what 2 factors? Well, it would increase oxygen carrying capacity, which is the first one. It also is going to increase viscosity. which is the thickness of the blood, making the blood slightly more difficult to pump. They lack a nucleus as mature cells. We saw that in the previous slide, the nucleus is shed. Now, why is the nucleus shed? Well, look at the shape. There's no space for a nucleus. And the nucleus is primarily there to repair the cell. Red blood cells don't need repair. They are disposable. So by removing the nucleus, it gives more room for the hemoglobin in there and increases the surface area to a volume ratio in them. They must be very small to fit through capillaries, and they can even fold in half. So there's no room for the nucleus, and they have to be full of hemoglobin. Notice that where the nucleus is, there's an indentation. Looks kind of like a Werther's. For the same reason Werther's have that shape, red blood cells have that shape, and that's to increase surface area. For Werther's, it's to give lots of butterscotch flavor to the person eating it, and for the red blood cell to increase the movement of oxygen in at the lungs and out at the tissues. So this shape is perfect for carrying and releasing oxygen. They cannot carry out metabolism or repair, so normally your spleen would check these, and if they're damaged, remove them. If you don't have a spleen due to a splenectomy, your liver would do that job. And what we'll find out later on is the liver does all kinds of really different important jobs in our body. Okay, so this is hematocrit. This is a figure directly from your text. This shows you for a normal person, the plasma would be here. Now, how would you get the blood to look like this? Have you guys ever heard of a centrifuge? Something that spins very, very quickly. What that does is it accelerates gravity. And because the red cells have iron in them, partly, they tend to go to the bottom. The buffy coat is white blood cell and platelets. The plasma rises to the top. So if you were going to put blood in a centrifuge, then you would see these different layers. This is an easy way to do it. So notice that the hematocrit is different. For females, it's slightly lower than for males. Males are anatomically, genetically predisposed slightly more for endurance activities. That's why generally males and females don't race against each other competitively. It's a sexist thing, but we are built differently based on our genders. Okay, so if you have anemia, you have depressed hematocrit or depressed red cells. This isn't the only thing that could lead to anemia, but a decrease in red cells could give you this. And if you have polycythemia, so question, what could cause polycythemia? What could make someone have really high red blood cell numbers? I told you about it just a few minutes.
Infection also cause these numbers to go up? Or
Generally, no. The
post-infection?
infection would cause the buffy coat to increase because that's more white blood cells. What would make the red cell count go up? I mentioned it just a few minutes ago.
Altitude?
Right, training at altitude. So a person who trains at altitude, when they did do a hematocrit test, would come out with polycythemia, meaning that they have more red cells than normal. Now, this is quite elevated, but somebody who's doing a lot of really heavy endurance training, especially altitude, could have levels similar to this. Okay, hemoglobin. This is a figure directly from your text showing you the different sections of the hemoglobin molecule. It's the oxygen-carrying pigment found in red blood cells. It's composed of 4 separate polypeptide chains. When they say polypeptide chains, they mean amino acids. So these tubes here are just a string of amino acids. Each polypeptide chain contains a heme group that has an iron atom at the center. And you see it right there. The heme is there with the iron Fe+2 in the center of that. Each of these positions is where an oxygen, diatomic oxygen is carried. Now the question is, why does it need to be so big? It needs to be so big because it can do a really important job, and that is to bind oxygen at the lungs and then release it at the tissue. So it's kind of like a junkyard magnet. You guys ever seen a junkyard magnet where they can pick up cars with a magnet, and when you turn off the electricity, the car falls? Well, this is kind of like a junkyard magnet. It binds oxygen tightly at the lungs when there's high oxygen content. And then when it gets to the tissues, it releases it. So it can grab hold and then let go depending on the situation. That's why it has to be complex in shape.
So does
Iron.
each red blood cell hold that much iron and hemoglobin?
Oh, this is just one molecule. The red blood cell would contain thousands or millions of these molecules. So each red blood cell could potentially hold several million oxygen molecules in there, and they would bind at each of these 4 sites. So this is very small. It's just been exaggerated to show its shape and structure. Okay. The lack of hemoglobin leads to anemia. So there's lots of causes of anemia, but it's really the lack of functional hemoglobin, oxygen carrying capacity, that is defined as anemia. Okay, recycling red blood cells. Older red blood cells must be captured by white blood cells in the spleen if you have one. If you don't, your liver does it. Many components of the hemoglobin are recycled. Now, you would think the body would have the good sense to hang on to the iron, wouldn't it? Well, it doesn't. It turns out the globular portion of the hemoglobin is retained and the heme group is dumped, and it turns into a thing called bilirubin. Have you guys heard of bilirubin before?
Yes.
Bilirubin is a component of bile. It's what makes bile green. Well, it enters your blood, your liver picks it up and turns it into bile in your gallbladder. All right, so non-recycled hemoglobin becomes
How does the hemoglobin aid in breaking down of food in the intestines?
it
Because that's
doesn't-
essentially what bile does, is to help break down the food.
Oh, wow, you're going a really big loop. Okay, you want me to do the big loop?
I don't know, do I?
Yeah, you do because you asked. All
I
right.
do.
Okay, so how does blood help you? Okay, you guys, this is going to take a second, but you got to follow me and I got to move through this pretty quickly. So when you break down blood, you get a material called bilirubin. It goes into your blood and the liver picks it up, right? The liver moves it into bile. Then when you eat fatty foods, the bile mixes with the fatty foods, helping you break the big chunks of fat up into little tiny chunks so that the water-based enzymes can get to it and break it down. So in a roundabout way, the breakdown products of your red blood cells help you digest fats. Does that make sense? I hope so. We will talk a little
Well,
bit.
you're saying it helps it digest it fast just because of the fact that it turns into bilirubin and goes into bile?
Well, yeah, it turns into bilirubin, goes into bile. The bile breaks up fat into smaller particles so that you can digest it. Remember, our ancestors wanted all of the calories that were in fat because they had to worry about starving to death. So you do want to break up fats into small little bits, which bile does, so you can digest it.
And is that the only way that bile's made is through the red blood cells that turn into
Yep.
bilirubin? Oh,
Well,
okay.
it's one component of bile.
Oh.
The bilirubin is a component of bile. There's a whole lot of other components to bile besides bilirubin, but it is one component, and it is the component that makes it green. So it goes from being red to green, which is weird. But anyway, it has to do with the oxidation of iron, I believe, but I can't remember exactly why it's green. Anyway, so if you guys have seen someone with jaundice, what happens is the high levels of bilirubin are not being removed by the liver because the liver is damaged in some way. For example, if someone has hepatitis, they're going to get jaundice, right? The hepatitis is damage to the liver, or any improper function of the liver is going to mean the liver can't pull the bilirubin out, put it into the gallbladder as bile, and therefore the bilirubin will continue to accumulate and making the sclera of the eye or the skin yellowish. So that's one of the diagnoses of liver disease is jaundice, and the jaundice is a yellowing of these due to the presence of high levels of bilirubin. So your skin isn't actually yellow, it's actually a very light green. So there you go. All right, what is anemia? It's lower than normal hemoglobin content. We saw that in the figure. The effect, blood cannot carry sufficient oxygen. What are the symptoms? Weakness and low stamina, because remember, to get stamina, you have to have oxygen carrying capacity. What can be some causes? Well, you can lose blood. That can cause you to be anemic. Some women, due to their menstrual periods, end up slightly anemic because some women lose a large amount of blood during their menstrual period. Hemolytic anemia, the cells rupture early, dumping the hemoglobin out. The problem is that hemoglobin gets processed out in the kidneys and cannot be retained, so you can't use it to carry oxygen. You can also have defective red blood cell or hemoglobin synthesis. For example, sickle cell anemia is an example because the red blood cells deform from that nice Werther shape into a sickle or banana shape when under low oxygen conditions. And that causes the red blood cells to get stuck in the capillaries, causing the cells downstream to become anoxic and potentially die. All right, what is the catch-22 of coagulation? Well, here's the deal. When you have a damaged blood vessel, you want to be able to repair it, right? In order to repair it, you have to decrease the pressure. If you want to decrease the pressure, you have to decrease the flow. Problem with decreasing the flow is you don't get as much oxygen downstream. So the catch-22 is we want to slow down the velocity and the pressure, but we still want to maintain flow through the vessel. So that's what coagulation is all about. Blood vessel cannot be blocked while the repair is underway. That would cause hypoxia. So you still have to have blood flow, but it can't be so much that it's going to cause massive blood loss from the injury. So the fluid is under pressure, so the patch must be strong to prevent leakage. So imagine taking a busted water pipe and fixing it while water is flowing through it and from the inside. That's what your blood vessels do. They have to be able to repair it while under pressure and while the fluid is flowing and from the inside. And that's the mechanism we're going to be talking about. So what are the steps? Well, first, pressure must be reduced long enough to seal the vessel with a clot. What is a clot? It's primarily due to platelets accumulating with a small amount of kind of spider silk is the analogy I like to use. You guys have all seen the Spider-Man movies when he flicks his wrist and a little blob of webbing comes out and sticks a bad guy out against a wall. That's kind of like how the platelets are stabilized. And I'll be showing you that later on. And then eventually, once that stabilized platelet plug has been there long enough, the body repair mechanisms take over. And what we're talking about is mitosis and healing of the tissues to repair the wound. As the wound heals, the enzymes dissolve the clot. So as the cells start to repair themselves, the clot gets dissolved slowly. Okay, what is the scientific term for platelets? Those are thrombocytes, cellular fragments produced in bone marrow. They're produced from megakaryocytes. I showed you a figure of that earlier on. So they just kind of pinch off a little bit of the cytoplasm containing small vesicles of clotting proteins. What are some characteristics? They're much smaller than red blood cells, which is saying a lot because red blood cells are very small. They're colorless and less stained, and they don't have a nucleus because they don't have to do anything other than act as sticky beanbags. The cytoplasm contains clotting proteins. They tend to stick to each other when activated. Okay, so this shows you the megakaryocytes. Notice the large amounts of endoplasmic reticulum. Why so much? This would be rough ER, by the way. It's because you're trying to produce large amounts of clotting proteins, which is going to be found in these vesicles within the platelets so that they can stick together when you have an injury. By the way, clotting is never supposed to happen unless you have an injury. Are you guys with me on that? So when a clot happens, normally that's due to an injury and no other reason. Okay? The platelets coagulate, form a plug preventing blood loss. So it's imagined like sandbags. Sandbags are bean bags plugging a hole from the inside. These are formed by fragmentation of megakaryocytes. Megakaryos means large envelope. It means there's lots of envelopes in here generating the proteins that are going to turn to platelets. What is hemostasis? Stasis means to stop, hemo, blood. So it means stasis or stabilization of the blood in terms of loss. The process of keeping blood within a damaged blood vessel is hemostasis. What are the major steps? Vasoconstriction. So what is the effect? It reduces blood flow and blood pressure, making it easier to repair. So vasoconstriction is going to reduce the cross-sectional area. The most important thing is the temporary blockage with a platelet plug. So these platelets just going to stick together in the wound to the vessel. Platelets stick to exposed collagen. As a matter of fact, the collagen is the trigger for the chain reaction that causes platelets to stick to each other. This causes the platelets to release cytokines, which act as a positive feedback mechanism, drawing more platelets to the site to stick. More platelets then aggregate, and eventually you're going to stabilize that platelet accumulation with thrombin and fibrin. We're going to talk about the functions of each of these in an upcoming slide. Okay, so this is how it works. Now, this is a figure from your text. I don't like it as well as others that I've seen, but fundamentally what it shows is that you have an intrinsic pathway, which is damage to the vessel wall, and the extrinsic pathway, which is trauma to the extravascular cells. But the idea here is you're going to have a chain reaction. And what happens is prothrombin, which is the inactivated enzyme, turns into a thing called thrombin. And now what thrombin is going to do is going to convert fibrinogen, which is a soluble fiber, into fibrin. And why is that significant? Well, it works very much like how Jell-O forms. If you guys have ever made Jell-O, you know that you mix it with hot water and it comes out very much like Kool-Aid, right? Then eventually when it cools, it becomes solid. And why does it solidify? because the fibers, the gelatin fibers coalesce and connect with each other, forming a gel. So what happens is the thrombin causes this liquidy material called fibrinogen to become actual fibrin, which is like fibers, like that spider silk. So prothrombin is converted into thrombin by a result of these steps that happen as a result of coagulation. I don't believe this figure is going to be an essay on the test because it doesn't really show it as well as I would like. It does show 4 distinct steps, but probably not on your test. But here's a pretty good figure. Also, well, it may or may not be on your test. If it is in your notes, it may be. But here's what's going on here. When the blood vessel wall is damaged, what you'll see is collagen fibers sticking out. That causes platelets to stick. When they stick, they release platelet factors. The platelet factors cause more platelets to stick. That's a positive feedback mechanism. And as soon as the blood is no longer being lost, this positive feedback loop stops. Now notice that these endothelial cells generally normally release prostacyclin and NO, which is nitrous oxide. What they do is they say, do not stick here because we are fine, we don't need you to stick. But when they are damaged, they stop releasing the prostacyclin and nitrous oxide, and the exposed collagen causes positive feedback loops, so it's kind of like a teeter-totter. Some people believe that the loss of the production of prostacyclins and nitrous oxide in older people or people with heart disease is part of what makes these platelets stick and what can cause a thrombus or what's the word I'm looking for? An accumulation of platelets here. Anyway, it'll come to me. All right, more about the platelet.
Are you thinking of embolism?
No, embolism is when a chunk breaks free and moves down and blocks a blood vessel. I was talking about occlusion or
Ischemia?
occlusion. What's that?
Ischemia?
Ischemia would be the result of that. That means lack of oxygen.
Right.
The word I'm looking for is like a chunk that you would find in a coronary artery that's blocking the blood cells from going past. I don't know why I'm blanking on that, but anyway. So what is the coagulation process? It's a series of enzymatic reactions that I showed you in the previous figure that ends with the formation of a protein fiber mesh that stabilizes the platelet plug. What are the 2 pathways to coagulation? Well, as we saw in the figure, there's an intrinsic, which uses pre-existing proteins exposed to collagen fibers, and the extrinsic, which is damaged tissue outside of the vessel, produce tissue factor, which is primarily thromboplastin. That thromboplastin is going to initiate a chain reaction leading to the conversion of prothrombin into thrombin, which then converts fibrinogen to fibrin. They both stimulate prothrombin, the inactive enzyme, to become thrombin, the active enzyme. And so now this thrombin is going to convert the soluble fibers of fibrinogen into the insoluble fibrin that stabilizes those platelets and platelet plug. Thrombin converts fibrinogen, the soluble protein, to fibrin fibers, which stabilizes. So you guys get the idea. This is the notes of what I've just been telling you. Okay, coagulation disease. So hemophilia is a genetic disease. It's the inability to clot blood. This is inherited, happened a lot to the royal family of Europe because they were marrying cousins. If you guys know anything about genetics, you're not supposed to marry your cousin normally. What's the problem is it's a rare inherited disorder. And if you marry someone related to you, they may have the same related genetic disorder. And many of these folks have the inability to clot their blood. They're called hemophiliacs because hemo means blood, philia means love. So these people love blood in that they need to constantly get transfusion, especially back in the day. Cardiovascular disease is the key problem. The clots block an undamaged blood vessel. So this would be like a thrombus. Anticoagulants like aspirin prevent coagulation. Now, a term that I've heard thrown around a lot is a blood thinner. What they do is they prevent unwanted coagulation. They don't make your blood thinner. What makes your blood thinner is by either having more water in it or having fewer red cells. So when you call it a blood thinner, it's really a misnomer because your blood isn't thinner. It's just not becoming unnecessarily thickened by clots. Does that make sense? And so the question is, would you use aspirin if somebody were in a trauma situation to treat a thrombus or an embolism or a blockage due to a clot? The answer is no, you would not. You would not use aspirin are preventative. They're not for treating a serious issue like a clot blocking a vessel. So the idea is, especially if people will take baby aspirin or buffered aspirin to prevent problems with the stomach, what aspirin does is it keeps platelets from adhering to undamaged blood vessel walls. Now, one of the review questions says that the drug used to prevent this is very rare and expensive. And the answer is false. Aspirin is very inexpensive. Does anybody know why aspirin is so cheap? And where it comes from? Where does aspirin come from?
I know it comes from the aspirin tree.
Close. Willow tree.
Oh, willow tree. Oh, okay.
So
Okay.
the way they figured this out is Native Americans would take willow bark and they would chew on it when they had pain, and the pain would be alleviated. What they found out is there was a chemical in the willow bark called acetyl salicylic acid, which is aspirin. And because it's grown naturally in the wild, you can't patent it and get rich from it. That's why aspirin is so cheap, and it works pretty well for reducing pain. It prevents fibrin coagulation, especially in undamaged vessels. Now, some people have reported that their relatives who use aspirin may have some reduced ability to clot during an injury, and some people have reported it does not reduce their ability to clot due to injury. So it just kind of depends on the individual and how much they take. What is the main risk? Could potentially reduce coagulation due to injury. How probable is it? Fairly low, especially for people who are on baby aspirin are less likely to be injured due to things like skateboarding accidents. So for example, most 60-year-olds don't skateboard or do things that are going to cause a lot of bleeding. But what about people in their 70s, 80s, and 90s? Do you think they could be bleeding more than the average person?
They would bleed more than the average person. They have less
Why?
collagen.
Well, they have less collagen in their skin, yes, but their balance is reduced and they can fall more and causing more bleeding. So you would want to be careful if you were the prescriber of giving someone aspirin at that age, because it could potentially lead to a bleed out. So often it's prescribed to people in middle and early older age, rather than people in their 80s and 90s. There might be other things.
What I meant when I said they have less collagen is that they're more likely to tear their skin. Their skin is
Right.
thinner at that point.
Right. So the fragility of the skin, but I also meant that they're more likely to fall because their balance is often reduced and their muscular coordination and strength is reduced often at those ages, right? So it's a combination factors. All right. Clot busters are not something you would take on a day-to-day basis. This would be what you would take if the medical provider diagnoses that there's a clot blocking a blood vessel. What it does is speeds a process called fibrinolysis, which is the breakdown of fibrin. And that's going to get rid of the clot that's blocking the blood. It can limit tissue damage by allowing red blood cells to get past the clot, especially to the heart and the brain. But you would not want to give this to somebody who is bleeding in the brain. So it would be important to determine, is the blockage due to a thrombus, which is a chunk of something, or to a rupture? Because in the rupture, you wouldn't want to give clot busters. You would want the blood vessel to clot so that you could get blood downstream to the rest of the brain. Okay, this shows you how fibrinogen is converted into fibrin due to thrombin. Thrombin also activates plasmin, which causes the fibrin fragments to stabilize the platelet plug. All right, that is our lecture for today. I moved through it pretty quickly, an hour and a half. So at this point now, so that I don't forget, I'm going to go ahead and show you guys the exam for this week. Let me see the essays. Oh, by the way, there was a little bit of a weird thing that happened when I was grading the essays from this last test. One of the essays was mistakenly assigned 1 point instead of 5 points. So when you saw it, you might have noticed it said out of 1. when I went back to grade it, I noticed that and I changed it to 5. So when you actually look at the test, it'll say out of 1, but your total score is out of 95 rather than 91. So that was just a typo that I had to fix afterwards. But you guys still all got the amount of points that you were supposed to get. Okay, so let's take a look. By the way, if you ever see something like that when we're going through it, and an essay is only worth 1 point, bring it up to me. It's going to make it way better than doing it at the end. Okay, so let's get to the exam, which exam are we in? Exam 4, right? And we're going to preview it. I'll let you guys take a peek at this. Well, bless my heart. Check this out. Look at, you guys have one essay for the test. I don't know what happened, but you just
Yay.
got it. Yay. Well, some people like the essays because they get a lot of points out of them. But there you go. You get to pick one of them. Notice it's 0 points, which means it's extra credit. So it should make getting through your test a little bit easier this week. So don't expect that every week. But I will tell you that your final has no essays on it. And I did that on purpose so that when you finish your final, you have your final grade in the class. You don't have to wait for me to grade anything. In addition, the last week has no labs. So as soon as you finish your final exam, that is your final grade in the class, unless it would round off to the next higher grade. So for example, if you had 89.9, that would round off to 90. Everybody else that's not in that position, whatever you have in your grade book at the end is the grade that you have for the course. And some of you may be tempted to say, oh, but Mr. Sage, could I just get a few more points? I really need that. Hey, nope, I don't do that. I don't add points just because you really, really need it. Okay. So
Is
please
the
don't.
final accumulation of all the chapters, or is it just the final couple
No, it's
chapters?
just the last 3 or 4 chapters. It's like any other test, but it doesn't drop, by the way. It doesn't drop because what I found is that if people had good scores up to it, they would just stop doing the class if they knew they could drop their final. So it's the only test that's not droppable. It's called the final, but it's only the last 4 chapters and it has no essays. So it should be fairly easy for you folks, but it is something you do need to take. And if you can't take it for medical reasons, you'll need to get an incomplete, but otherwise, whatever you get on that is going into the grade book. So that's one you don't want to miss. And you don't want to screw up. Okay. So there you go. There is your one and only
Credit essay, right?
what's that?
So just to confirm, it's an extra credit essay. It's an
Yes,
option.
that one for this week is extra credit only. There's no regular credit. And on the final, there's no any essays. There's no extra credit on the final. And by the way, folks, please don't ask for an extra credit assignment at the end to rescue your grade. I don't do that. The only extra credit I provide is on the exams as extra credit essays. That's the only way to get extra points. So please don't request an extra credit paper or something that can get you from a C to an A at the last minute. That is not how badgers work. If you guys remember my first lecture, I talked about badgers. Okay, so now it is time for review from the chapters going to be on this week's test. And that is going to be, so we're in week 5, right? So it says that we're doing 19, 20, and 18 for this week's exam, which we just covered. Now, unfortunately, we just covered it. So you guys should have done the review questions in advance so that we could go over it. If you guys did, then what I would like to do is start with chapter 19 because it's the first one listed. So get out your chapter 19 notes. And if you have your review questions done, I'd like you to pick one that you had difficulty with, or you just want to double check to see if your answer is correct. Who would like to start us off with a question from chapter 19?
Can I do 19?
19, read it, please.
What type of valves would you find between atria and ventricles and arteries?
Okay, so between atria and ventricles would be the AV valve. You guys remember I showed you that they were large. They had strings attached to them called chordae tendineae, and they are attached to papillary muscles, highly reinforced. Those are atrioventricular valves. Different valves are between the ventricles arteries, and those would be semilunar valves. Those are non-reinforced, no chordae tendineae, no papillary muscles. Okay, so AV valves and semilunar valves.
Thank you.
Okay, you're welcome. I'm gonna open up the chat.
You said we're
Uh,
being tested on 18, 19, and 20?
Yes, I believe that's what it says, 18, 19, and 20, but we did them in the order of 19, 20, and 18, right?
And just to confirm, is this 20 A, B, and C?
Yes, all parts of 20. All the parts of 20. Right?
Was 19 last week?
No, it was 15.
It was 15.
19, part of 19, was that last week?
Last
don't
week
know.
was chapter 19 and 20 combined. So chapter 19 and 20A.
Okay, and then 18 was,
18, 20, B, and C were for this week.
okay. So guys, all of 18, 19, and 20, and all of 20 is going to be on the test. I believe that that's what it is. So just prepare for that. Okay, so but right now we're in chapter 19. So let's focus on that. Can you guys give me more review questions that you'd like some explanation or help with?
Someone asked for 6.
6. Oh, there we go. Casey says, why is the human circulatory system closed? Now, closed means that the blood stays in blood vessels all the time, except for when you're injured or when a woman is pregnant. But some animals, like insects, and believe it or not, insects are animals, have an open circulatory system. That is, the blood just kind of trickles over their tissues and is gathered at the bottom. So they have an open circulatory system. We have a closed circulatory system with a couple of minor exceptions. Does that help, Casey? All right, who would like to do another one? John asked number 20, how are AV valves different from semilunar valves in structure? I just gave that to you, John. AV valves are more reinforced with chordae tendineae and papillary muscles, whereas the semilunar valves are not. Okay, so that's 20. Anybody else from chapter 19? You're welcome, John. Anybody else from chapter 19? Is that where we are? Anybody for chapter 19?
2. What
Read
are
it.
the major differences between the atria? Actually, never mind.
Okay. Anybody else? Chapter 19. All right. Hearing none. Let's go to
Someone asked for
chapter.
23.
Okay, you got to jump in a little quicker. All right. Number 23. Is that what you said?
Yeah, it says,
Okay, read it.
what are the major functions of the desmosomes in the heart tissue?
Desmosomes. Gosh, my brain is blanking. I think it's to transfer force. It's right in your notes. If you look in your notes, look under coronary or cardiac cells and look under desmosomes. I think it's to transfer force. Yeah, I'm pretty sure it's to transfer the force from one cell to the other. But
Yeah,
check-
it says, yeah, cell to cell connections, transfer
cell-
force.
physical. Yeah, there you
Yeah.
go. Okay. Anybody else? Chapter 19.
37.
37, read it.
What do EDV and ESV stand for? What can they be used to calculate?
Okay, the first one was EDV and ESV. So the end diastolic volume and end systolic volume. And when you subtract end systolic volume from end diastolic volume, you get stroke volume. What that means is how much blood has left the heart. Okay.
So their purpose is used to calculate stroke volume?
Yes.
Okay.
Well, I mean, they represent volumes. That they're just telling you what those volumes are. And if you subtract one from the other, that gives you stroke volume. Okay.
And you said stroke volume is how much blood is
How much
left.
blood leaves the heart in a single ventricular systole or contraction. Okay. Anybody else from chapter 19? We got to move on here pretty quick. I'm gonna go ahead and call it. So can you guys please get out chapter 20? Chapter 20, and look at your review questions. Were there any you had difficulty with?
Are we pulling out 20A, B, or C?
Yes.
Which one?
Well, let's start. How about we start with A? Let's start with 20A, folks, because that's the first one.
It's combined with chapter 19.
Uh-huh.
Okay.
So would
So-
it be 20B?
Yeah.
Okay, so 20B, whatever our next set of notes is. So 20B, you guys have 20B there?
Yes, we're pulling it out.
Okay. Who would like to start us off?
$35.
Okay, 35, read it.
What feedback mechanism can lead to the death of a person in shock?
So which feedback mechanism is the problem? Is it negative feedback or positive feedback? That's the problem with shock.
Positive?
Positive feedback, because you guys ever heard the term death spiral? It means what's happening to you is making the situation worse, and it continues to get worse and worse unless intervention happens. Okay, so yeah, positive feedback loop. Okay, any others from that chapter?
Can we do number 7?
7, read it.
Which of the following is not a function of epithelium of the blood vessels?
Well, just know the ones that are, and any of that aren't one of the ones that you that's listed there would be the right answer, because you're looking for the one that does not fit with the others. Okay, so what most of my students do is they change it to what are the functions, and then on the test, when you see one that's not a function, and by the way, that question is one of my least favorite, which of the following is not, because it's kind of tricky. So you'll rarely see that on my test, once in a while, but it's got a low probability because I don't like them and I wrote them. Okay, let's see. Who is this? Person asked a bunch of questions. John. John asks number 19. What can angiostatin and endostatin do to assist doctors and their patients? That is to reduce blood vessel growth into a tumor and starve it. So that was 19, and he did 19 twice. Okay, so there you go, John. Anybody else from this chapter?
Yeah, I have a question. For number 9,
9, go for it.
it says the layers of smooth muscle and blood vessels have what 2 opposing functions?
Okay, so when they contract, what is that called?
A vasoconstriction,
There you go. And when they relax, what is that called?
vasodilation.
Are those opposites?
Okay, yes. Okay,
There you go.
thank you.
Vasodilation and vasoconstriction. Good. Okay, excellent. Let's keep going. Anybody else from this chapter? No?
Septic shock is also known as what? And this is number 32.
32. One more time, Catherine.
Septic shock is also known as what?
What was the other term for it in your notes? Anybody get it? Toxemia. Very good. Toxemia. Brianna got it. Good job, Brianna. Toxemia can sometimes also be called septicemia, but toxemia is what's in the notes. Okay, good. Who would like to continue? Any others for this chapter? Okay, guys, I got to move on because I got to go get my kid at 3:20. What's our last chapter? Or are we now on 20C?
20C and 18.
Okay, 20C, get out 20C. We're going to move on to that. Who has one from 20C?
I have one. 6.
6, read it.
Why is bulk flow move out on arterial side but not on the venous side?
Okay, well, if you remember my lecture, bulk flow moves out on the arterial side because the blood pressure on the arterial side is higher than the osmotic force. So it goes out. But it goes in on the venous side because the blood pressure is lower than the osmotic force. So it has to do with a drop in blood pressure from the beginning to the end of the capillary bed. Okay.
Thank you.
Yes, Matthew, you can send your questions via email, but please make sure that they have answers, because if you send them blank, I don't just fill them in for people who just send me the blank questions. But yeah, I'd be happy to do that. Try to pick the ones that you most have concerns about. Some people send me like 50 and it takes forever to get through. So just pick the ones that you most want to know. And yes, I'll be happy to do that. Okay, anybody else from this chapter? And yes, you guys are all free to send them through email if they have an answer associated that I can
I'm
tell you
sure
made
for 28.
28, and then John has 30. Read 28, please.
Lymphatic fluid is essentially the same as interstitial fluid. Is it true?
True. Remember I said the only difference is location.
Oh, thank you.
You're welcome. John says, number 30, everybody, how is pumping of lymphatic fluid accomplished? Well, there's 2 major ways. The first is in large vessels. Muscular pumping can do it, but primarily it's due to compression of the fluid and by valves. So when the tissue is compressed, it squeezes the lymph out, and the valves make sure that it constantly moves back towards the vessels above the heart. Hope that helps, John. Anybody else on this chapter? Exam 4 is due. Oh, wait a minute. What is it? Wait, what does it say? Exam 4. Let me look at that really quick. We have the wrong due date on that. What is the due date? It says July 17th for me. When I look at it, it says July 17th. What makes people think it was 10th of July?
Because this Sunday's the 10th.
Oh my goodness. Well, then it should be the 10th.
Do we not have an exam
It's
that's
a whole week.
posted
It's a
for the
whole week,
17th?
yeah. No. We're gonna do the 10th. Yeah, so wait a minute. Let's see. Hold on a second, folks. Yeah, that's a typo. Okay, so yes, it is July 10th. I am sorry. Yes, that was a mistake. It's July 10th, which is Sunday.
Exam 5 will be due then on the 15th.
Guys,
I mean, on the 17th.
guys, I need to take a quick pause. Can you guys hang tight for just a second? I'll be right back. Just hold tight. I'll be right back.
Vale. Vale.
Okay, so exam 4 is due guys, it's always due on the Sunday of the week it's assigned. And just remember, always use the start here to determine when stuff is due. If I have the wrong due date listed, don't worry about when it says it's due. It's always due on the Sunday of the week it's assigned. But thank you for letting me know. So yes, so exam 5 should be the 17th, and the final would be, oh, by the way, you guys, the final is due on a Thursday night because that's when the class ends. I can't extend it past then because Thursday night is the end of the class, so you guys have to get your final done by Thursday. Hey guys, I have a emergency that just came up that I gotta take care of. I'm really sorry that I won't be able to get to the rest of your review questions or going over your old exams. But if you want to send me your concerns through email, I'll look it over, and if you're entitled to more points, I will give that to you. Also, if you have review questions that I haven't answered, please just send those to me through email. I got to take off, you guys. I'm sorry. Hey, have a good rest of your week. Good luck with the test, and I hope to see you back on Tuesday. Bye,
Thank you.
guys.
You too, bye.
Bye-bye.